All right, well, welcome back to Ultrasound Grand Rounds this week. Pretty excited as always to be back with you. It's a snowy day here in Cleveland. A lot going on just outside with the weather, kind of making it hard to get in. But we are warm and cozy here. We're going to get some ultrasound on here. We're going to talk a little bit more about gallbladder ultrasound. So last time we met, we basically left off with this thought that we talked about the normal gallbladder, right? We talked about kind of what it is, where it is, kind of normal anatomic structure, kind of what it does. And then looked a little bit at the gallbladder, just sonographic appearance, right? And so if we cut over to this, we can see, this is kind of what we talked about. We showed this image about we have the gallbladder and long axis, how it's a blind-ended pouch, how it's generally anechoic unless there's something wrong with it. We want to look at the fundus, body, and neck in the long and short axis, as we see here. And then we looked about how to find that common bile duct, right? This is kind of the challenging part for everyone who's learning gallbladder ultrasound. As they're kind of getting into this, is finding that common bile duct. And I know I had an opportunity with one of our residents to kind of work through that this week. And so with that foundation that we established last time, we're going to move on today and we're going to talk about gallbladder ultrasound part 2, and that is the fun stuff. That's the pathology, right? And so we're going to talk about cholelithiasis. We're going to talk about cholecystitis, how we can find that sonographically, what that means, and then look at some literature as we wrap up today's hour to see kind of that, show that this is something that we can feasibly do in the emergency department, and it actually provides meaningful benefit to the patients that we serve. So with that said, let's dive right on in. Let's go into cholelithiasis, right? So by definition, this is gallstones, right? And just kind of again, backing up big picture, gallstones, they're basically a precipitation of the bile salts, things that are in the gallbladder. And kind of like you can get stones in your kidney, you can get stones in your gallbladder, right? They form these, this hard, precipitate structures essentially. And if they're just hanging out in your gallbladder, really no biggie. But once they start trying to move out of your gallbladder and getting stuck, then it can result in, various things that we know and love called, gallbladder pain or biliary colic, right? And this oftentimes results, from stasis of the bile, or these sludge or the things like that, and they can accumulate. And so most of them are these going to be these cholesterol stones. Some of them are going to be pigmented stones, and then kind of this mixed picture. And I was doing some cursory looking up this week, is there a way of identifying which one's which sonographically? And, there may be some tendency in the pigmented stones to be the smaller stones. There may be some tendency in the cholesterol stones to be the larger stones, but I haven't found anything that says definitively, like on ultrasound, when you see this, it's a cholesterol stone. When you see this, it's a pigmented stone. And honestly, it doesn't really matter other than for academic purposes because the management's going to be pretty much the same. So anyway, it's kind of a big picture of gallstones, what they are. Now, the question is, who are we expecting to see this in? And there's a number of risk factors that are commonly associated with biliary disease, and that's going to be people as we get older, right? Women tend to experience this a little bit more than men, though it's not exclusive. Tends to be something that you see in people who tend to be obese, diabetic, or postpartum. And so I found it actually very common in my practice. When you have a patient who's like, particularly a female patient, right, who says, they got right upper quadrant pain or upper abdominal pain, and they say, yeah, I've got X many kids, it's not uncommon to actually find some gallstones in those patients because, that's the constellation of some of these risk factors. Now, clinically, it's going to present on kind of a spectrum of disease, right? So we call pain that's referred to your gallbladder from gallstones biliary colic, right? And so if you have a gallstone that's in your gallbladder, it contracts and it gets stuck in the neck, it's going to cause some pain, right? And that's, like I said, biliary colic. And that's kind of on the spectrum of disease in this whole idea of cholelithiasis. Now, what can happen is as these stones get stuck, right, they can cause some distension, right, of the gallbladder. That gallbladder can then become inflamed and potentially even infected. And that's when we start tipping towards the side of the spectrum that we're going to call cholecystitis. We'll talk about that a little bit later. But there's a whole spectrum of disease where you can have someone come in and says, hey, I had a slice of pizza today. My gallbladder, or my right upper quadrant started hurting. And it hurts for an hour or two and it goes away and I'm fine, right? That's a different patient compared to the person who says my gallbladder or my right upper quadrant has been hurting nonstop for 3 days. If I eat something, it gets worse, but it's just the pain will not go away. Similar disease, etiology, but maybe a little bit different place on the spectrum of disease, and potentially then the management strategies for these patients with biliary disease, right? And so just understand that this is kind of a spectrum of things that we're going to see, in our patients clinically, and we're going to have to then interpret what do we see clinically with what do we see sonographically, and then make some decisions about how we're going to, get our surgeons involved and kind of what next steps are going to need to be taking place for these patients, right? So with that background in mind, let's switch gears and talk a little bit about the ultrasound side of things, because that's really what we're here for. We're here to learn, how do I determine whether this patient has gallstones, and then how do I determine whether those gallstones are the thing that's causing the patient's pain, right? Because they're coming in with right upper quadrant pain, and what I want to know is it the biliary system, or do I need to move on and then find something else that's causing their pain, right? So cholelithiasis from a sonographic standpoint, right? So it generally presents with right upper quadrant or epigastric area pain. You can also have symptoms like nausea, like intractable nausea and vomiting that can be presenting in this way as well. And it results from the gallbladder contracting against an obstruction with the duct, right? And so depending on the size of the stone, it may or may not pass through, right? And if they're really teeny tiny stones, they pass right on through, no harm, no foul, you probably won't notice it. But if they're big enough to get stuck and get obstructed, you can imagine if you're taking, a water balloon and occluding the outlet and then squeezing the balloon, what's going to happen? It's going to put some stress on that balloon. It's going to cause some pain there. And so that's what's going to happen here. And like I said, it's often stimulated by eating something that causes that gallbladder to contract. And if you want to hear more about that, go back to the last discussion that we had where we talked a little bit about the physiology about how that contraction then takes place, right? So from a sonographic appearance, these gallstones can appear in multiple different ways, right? You can have some that appear as just single discrete stones, and you can have it appear as just kind of this confluence of layering small little stones, right? It can be anywhere from gravel up to just big boulders, right? And I had several patients that I scanned in the last couple weeks. They had the bigger stone size, gallbladder or gallstones. But definitely over the course of the time that I've scanned, I've seen, many, like you can have layering stones, you can have big stones, right? There's a couple unique factors that these gallstones will exhibit that really help us identify that they're there, and show kind of, what's going on. And that is, they're going to have a hyper reflective anterior surface, right? And they're going to have some shadowing, right? They're going to be some deep, dark shadowing. And what happens here is you have the sound that hits the surface of the stone, right, interfaces with that stone, reflects back or is absorbed by that stone, and then we have a paucity of sound deep to that, causing that shadow. So all these big stones are going to see that. Where you may get, you may find some interesting nuances is with the super duper small stones. So when you have these small stones that are kind of all lumped together, they tend to kind of work in aggregate to create this hyper reflective anterior surface and the shadowing deep to that. But if you have like a one-off stone here and there, it may be small enough that it's not going to cause a deep shadow. And so generally somewhere in that 2, 3, 4 millimeter range, if they're isolated, you may struggle to find a shadow. Whereas if you put them all together, they'll end up shadowing here for you. Other features here is they tend to layer dependently, right? They're gravity dependent things. So they're more dense than the bile around them. And so they're going to sink to the bottom because of gravity. And so if you roll the patient, right, if you have them on their back, roll them to the left, roll them to the right, you should notice a movement of these stones relative to other structures in the gallbladder, depicting this mobility that shows that this gallstone is there, but kind of not impacted, right? And so the way I generally look at this one is if you have gallstones, right, if you have right upper quadrant pain, you see gallstones, you're probably operating in the right territory saying that this gallbladder is causing that pain. However, the stones that are moving around are not the ones that are actively causing the patient's pain, right? Because they're not obstructed. There's probably one that you're missing somewhere in the ductal system that's actually causing this patient's pain. And one of the patients that I scanned in the last couple of weeks was very much this case, right? We had a large stone in the gallbladder fundus. Great, that doesn't really explain the pain because it moves around. But then when we scanned a little bit more thoroughly and found, just really analyzed that neck, we found one that was hiding in the gallbladder neck. I'm like, there's the problem. That's the one that's causing this patient's discomfort. And so it's really important when you see these things that you move the patient, right? So if they're lying supine, move them to the left. If they're on their left, move them to their supine. Sometimes we've even rolled people to the right or sat them up just to demonstrate that these stones are or are not mobile as we're trying to evaluate kind of what's going on, with these patients here. So here's an example, just some arrows showing that reflective surface on that stone with the deep, dark shadowing posterior to that stone that's coming from that reflection. So the question then is why, right? Why does this do this? And I always like to not just understand what's going on, but the why, so that I can maybe take that knowledge and then apply that elsewhere, or help better understand it so I can understand the nuances a little bit better. And so this all comes as a result of an impedance mismatch. So we're going to dive into just a touch of physics here for the next minute or two. So basically, every tissue has a certain acoustic impedance, right? And the impedance is by definition the property that causes that tissue to resist the transmission of sound through it, right? So if you imagine yourself like running down the street on a windy day, right? You feel the wind in your face, you feel it's a little bit harder to run into that headwind. That's to some degree a rough correlate of the impedance, right? The ability that air is resisting my ability to move. And maybe a better example is, try walking down the street. It's pretty easy. Then hop in a pool and try walking from one end of the pool to the next, right? It's going to be a lot more difficult because you have to walk through that water, and that water has a higher degree of impedance to your movement, right? And the same principles apply to sound. And so whenever you have a sound interface or a tissue interface, you're going to have a tissue with one impedance stacked up next to a tissue with a different impedance, right? And if there's a similar impedance, the sound will travel right on through it. But if there's a difference in impedance between those two tissues, right? One has a very low impedance, one has a very high impedance. There's gonna be a huge resistance at that interface, right? And that resistance causes a reflection of sound, and that sound is then reflected back towards the source that it came from, right? And so when you have this mismatch, right, you're gonna have a reflection, right? And there's gonna be less that's transmitted through. That's what we're trying to illustrate in this picture, right? Z1 is the impedance of the tissue 1. Z2 is the impedance of tissue 2. And so in this situation, imagine Z1 is the bile around the stone. Z2 is the stone itself. There's going to be a huge impedance mismatch, which is going to cause a profound degree of reflection of that sound back up towards the transducer, causing that hyperechoic white rim around that gallstone, right? Because the stone's really not going to allow the sound to penetrate through it. Now this can be shown a little bit more mathematically on a table, right? Most soft tissues you can see here, like fat, liver, blood, kidney, muscle, all kind of live in a very similar range of impedances, right? 1.3 to 1.7 or so. There's a few outliers, right? Air on the low end and bone on the high end, right? And so this is helps us see mathematically why ultrasound doesn't see through air very well, and why ultrasound doesn't see through bone very well, right? And why there's a profound degree of reflection at that air tissue interface and a profound degree of reflection at the air bone interface, right? And so bone absorbs a lot of this sound, it reflects a lot of the sound. That's why you get that deep, dark shadow posterior to that, right? With air, there's a lot more scattering in that reflection, and so that's why we get some of that grayscale artifact deep to it, not the dark shadowing as opposed to the bone. So hopefully that helps us understand kind of why the gallstone does what it does and produces that shadow. And so we'll kind of move back out of the physics realm and back into the clinical realm here. But what we can see though is, when we have the bunch of small gallstones, right, you have a whole layer of them, you see that bright white, interface between the bile itself and the gallstones, causing that, the reflection and that deep dark shadowing, right? And so we see here in transverse and long axis, or long axis on the left, transverse axis on the short, or on the right, or the short axis, what that will look like. And one of the things I found challenging, at least initially when I started doing this, is sometimes this air or this bile stone interface can look very much like the posterior wall of the gallbladder air interface of a loop of bowel next to it, right? It can be easy to pass by it, especially if you're kind of new at this. And so when you're doing this, you want to scan, carefully, right? Really find the tissue, the wall, the border of the gallbladder, and look and see if that's interrupted by the stone layer. Because what you're going to see here, and it's a little bit more evident on the right-hand image, the transverse image, that you see a nice curve of the anterior and the lateral walls, and then just a sharp line, right? That layering line of gallstones, so these small gallstones that cuts off the normal geometry of kind of that circle that you'd see as you're going around, right? So that's one of the things that you can look for. The other thing to look for is just the shadow, right? So if you have a loop of bowel that you're looking at, you'll have kind of that grayscale shadow, that kind of dirty shadow. Whereas if you have gallstones, a layer of gallstones, you tend to have that dark black shadow. So as I'm scanning through this, yes, I'm looking for the hyperechoic rim of these gallbladder or gallstones, but my eye is oftentimes looking posterior to the gallbladder and looking for shadow patterns. Because if I see this dark smudge of a shadow posterior to the gallbladder, then I'm a little bit more concerned that there's some stones in there, causing the patient's symptoms and presentation. So a little bit of trick there with the small gallstones. So those can be challenging. The big ones, right? Here's an example of some big ones. They tend to be a little bit easier, right? You see this big old boulder inside the gallbladder lumen with a deep, dark, posterior shadow, deep to that gallstone, right? That's kind of hard to miss that as you're scanning through. But the caveat here, right, the nuance or the thing that kind of improves your scan is if they're symptomatic and you see a big boulder, right, particularly if it's mobile, that's probably not the only stone, right? There's probably another one somewhere in the duct, right? And if they have one big stone, they probably have another big stone. And so you really, really want to scrutinize that neck, right? You want to scan down in multiple different ways, get that neck, roll the patient to the left, kind of really get into that neck in long axis and short axis to find and make sure that there's not another stone that's buried in that neck somewhere. And I've had multiple occasions over the years where, a quick cursor, you're like, oh, there's stones there. Great. And then when we look a lot more closely, you find that one that's impacted the neck. And where this becomes an issue is if you report out that you have a single mobile stone to the surgeons and they have pain, the surgeons are going to be like, okay, whatever. If you report out that they have an impacted stone in the gallbladder neck, that's going to catch the surgeon's attention, right? They're going to want to be a little bit more aggressive with that patient because that stone that's impacted, that won't move, even when you roll the patient from the left to the right to sit them up on their back, things like that. When it won't move, that significantly increases the risk of complications for that patient, right? It significantly increases the risk that the patient's going to end up with cholecystitis or something worse. And so the surgeons will oftentimes be a little bit more aggressive on those patients than if they just had, a single mobile stone that, the pain maybe went away or you get the stone to move. So anyway, hope that helps for the large and the small. One other thing that you're going to run across, in the consideration of normal cholelithiasis picture is something called the wall echo shadow sign, right? And so the theory is, okay, if you have a layer of stones, you're going to have your gallbladder anterior wall, you're going to have some bile in there, you're going to have the stones at the bottom. It all looks pretty good. There's a lot of contrast, so it kind of catches your eye. But what if that gallbladder is so full of gallstones that there's no room for the bile in there anymore, right? It's all stones, right? Based on the physics principles, what you should see then is essentially the anterior surface of the gallstones, right, in a deep dark shadow. And that's it, right? And this is what we're looking at with the wall echo shadow sign, right? You'll see the wall, the anterior wall. You'll see the echo, right, that the gallstone surface or interface, and then the shadow, right? And you won't see anything else. And these I found are particularly challenging when you're scanning. Like conceptually, like, oh yeah, it totally makes sense. The gallbladder is so full of stones that I, won't be able to see anything. And, the pictures I have here, like, okay, I see that. But when you're scanning by, it can be frustrating because you cannot, for the life of you, find this gallbladder. And that's because all you see is the stones in the shadow, and your mind is trying to find that blind-ended pouch, that lumen, that anechoic lumen that we talked about all last week or last time. And so what I found to be particularly helpful here is, again, look for that shadow. Like normally, if you have a contracted gallbladder and just loops of bowel kind of filling its place, you should have kind of this dirty shadowing, right? Everything should just be kind of this mid-block gray, right? As you scan through someone who's got a wall echo shadow, right, you really have to know your landmarks, right? Your fast exam view, it'd go just anterior to that. And all of a sudden, if you just have this just black hole, right? And not even black hole, just black smudge that I don't know what this is. It's just completely black on my screen. That probably is your wall echo shadow sign, right? And you're seeing in long axis that anterior surface of the gallbladder and then just shadowing deep to that, right? And one other trick that can be helpful as you try to identify this is turn your probe into short axis, right? Turn it transverse. And what you're going to see is you'd expect to see that gallbladder kind of in that circular formation, right? That transverse view of the gallbladder. And instead of seeing a lumen, you're just going to see this black, this upside inverted U in black shadow, like we see on the right-hand image here on our screen. And it will be kind of in the shape of a gallbladder. And so if all you see is a shadow in the shape of a gallbladder, you have to be concerned that this patient may have, what we call this Wall-Echo shadow sign or West sign of just a gallbladder completely full of gallstones, right? So those are kind of some of the three different scenarios that you may find yourself again. And again, just to kind of reiterate and kind of pound this home, always be sure to check that neck, right? So this is a study that we did, easy one to pick up in the gallbladder fundus or gallbladder lumen, right? Not quite in the fundus yet, but in the body of the gallbladder. But if you're not careful, you'll miss that second one that's down in the neck, right? Particularly if all you see is kind of that hyperechoic rim and you kind of miss that shadow at first, right? This one's pretty easy because there's two shadows. But sometimes when it's buried down into the tissues, it can be difficult to kind of pick up that shadow a little bit. And so really be careful, scrutinize that neck for that one that's impacted, because that's going to have a huge impact, sorry for the pun, on the patient's outcome. So with that said, there's a couple mimics that we need to be aware of, right? A couple things that we want to think about as we're looking through these patients with biliary disease, right? And the mimics are polyps, sludge, clot, and non-shadowing stones, right? And so just kind of processing through these. Here's a couple images I found off the internet of gallbladder polyps. So polyps are basically echogenic things inside the gallbladder, right? So we kind of define gallstones as these echogenic things inside the gallbladder, but they have that hyperechoic rim and they have the deep dark shadowing posterior to that. Polyps tend to be these echogenic things that don't shadow, right? And they generally tend to be non-mobile because they're adhered to the wall, right? If they're not adhered to the wall, they're not a polyp, it's something else, right? So they're adhered to the wall, they're echogenic, they don't shadow. You move them from left to right, sit them up, lay them down, the things don't move, they're always in a fixed position, right? Then you call it a gallbladder polyp. The ones that are small tend to be pretty benign. If you have this pedunculated polyp, not a huge deal. It does need follow-up to make sure it doesn't become something bigger and worse. But you can have gallbladder polyps that tend to be benign. However, as the polyp gets bigger, right, that increases the risk that this is not just some benign pedunculated polyp, but a malignant lesion, right? And I think, I don't have the reference to quote here, but our surgeons, if I remember correctly, have quoted to me that if it's over a centimeter, that's surgical criteria for a cholecystectomy, because it's just the risk of malignancy. But if they're over 5 millimeters or so, you definitely should have them following up, in the very, very short term to make sure there's no change in size, right, of these gallbladder polyps. So generally when I run into a polyp, I'll always comment on it. I'll always recommend that they get a comprehensive ultrasound to follow it up, if for no other reason to share the liability, but also just to make sure that there's no change in size, that would be a harbinger of kind of a worse polyp, as this patient kind of goes forward in time, right? So that's the first thing to keep an eye out for. The second thing is gallbladder sludge, right? So this is very commonly seen, right? It's technically not gallstones, right? But gallbladder sludge, according to one of the sources that I was reading, is this thick stuff, right? You can see it here layering out in the posterior portion of the gallbladder, made up of different mucins and glycoproteins and calcium and different pigments. And there's sometimes this crystallization of cholesterol and calcium bilirubinate that creates kind of this sandy, sludgy mixture of stuff, right? There's some debate, but I think it's generally considered to be a something that's a risk factor or can potentially develop into gallstones, but it's something to keep an eye out for, kind of as you're scanning through these patients, right? This is gallstone or biliary sludge. It should be mobile, so if you roll the patient, it should kind of layer out in gravity-dependent areas. And interestingly, typically it's kind of this murky stuff that kind of layers in the bottom. However, it can kind of not precipitate, but kind of form up in these rounded structures, right? Called sludge balls or tumefactive sludge. And essentially it's an aggregation of sludge kind of in the gallbladder. So here's an example of a patient that had multiple different things going on. There's a couple gallstones. You can see that big gallstones with the deep shadowing, but the arrow there is pointing to this echogenic thing adjacent to the gallbladder. And when you roll the patient, it's mobile. So it's not suggestive of a large polyp. And this would just be tumefactive sludge. Now, if you look in the literature, some people would say that you should throw color Doppler on these things, right? And if you have color Doppler, that pushes it towards a polyp. However, a lack of color Doppler inside this thing does not rule out a polyp. And so your better thing is to say, does the thing move, right? A tumefactive sludge, you should be able to roll the patient on their side, and it kind of rolls down into the gravity-dependent area. And then roll them on the other side, and it rolls back to another gravity-dependent area. So just something to keep an eye out for as one of these mimics of gallstones that we're gonna see here. So that's cholelithiasis, right? We're kind of on that left-hand spectrum of that graph that we showed earlier. Now let's move to cholecystitis, right? Because this is the big thing that we want to worry about. Cholelithiasis potentially can be dealt with as an outpatient, depending on, what the patient's lab values look like, how they're responding to their pain, things like that. But cholecystitis is a thing that we need to really identify and intervene upon a little bit more acutely, right? So cholecystitis is basically a complication of biliary disease or gallstone disease. It's seen in the ED in about 5% of patients with abdominal pain. And it results in inflammation of the gallbladder, right? And so we've talked about inflammation in this forum before as those multiple characteristics of rubor, tumor, color, dolor, and move no more, the lack of function, right? So redness, pain, swelling, warmth, and then loss of function, right? And so we can't always see some of these, so like the rubor becomes less of an issue, but the same things that cause that redness of the skin, right, in the inflammation of the skin happen here. So you have that hyperemia, you'll have the swelling, the inflammation that happens kind of in this gallbladder. And so what you can see is basically the effects of that on our ultrasound, and we're going to look at that over the course of the next several slides here. But it's important to note that there's a whole spectrum of disease in that whole cholecystitis picture. So you can have acute uncomplicated cholecystitis, or acute cholecystitis, where you just have the obstruction with the gallstone. You have inflammation, but then it can progress all the way to like a necrotic gallbladder, an emphysematous gallbladder. You can have a perforated gallbladder. It causes all sorts of things. You can have an adjacent, abscess, as a result. So there's a lot of complications that can happen as a result of cholecystitis, which is why I want to get the thing identified and then managed, right? From a pathogenic standpoint, basically you have an obstruction of the duct at some level with your gallstone. It's going to cause some distension, irritation, triggering an inflammatory cascade, and then sometimes you can have secondary bacterial infection as a result of that whole process, decreased immune defenses and things like that. You can get that infection in there. So sonographically, what are we looking for, right? We're looking for those evidences of inflammation in the gallbladder, right? So the first thing is you put a obstruction, right, in the outlet, and what's going to happen? You're going to get distension proximal to that, right? If you have a water balloon and you plug it up, if you have kind of stuff going into it and you plug up the outlet, it's going to keep getting bigger, right? You're going to distend the thing. And so what we'd expect to see sonographically is some biliary distension, right? We'll show a picture of that here in just a sec. Followed by some thickening of the gallbladder wall, right? Remember, the inflammation causes thickening because of the edema, right? You're going to see that reflected in the gallbladder wall here on an ultrasound with gallbladder wall thickening. You can have some pericholecystic fluid, right? It's kind of that inflammatory fluid kind of leaking out around the gallbladder. And then finally, we're going to have exquisite tenderness over the gallbladder, because this is the thing that's causing all of this pain, discomfort, and the problem, right? When you put your probe on there and push on top of that gallbladder, the patient will say, ow, that's where it hurts. And that's the sonographic Murphy sign, right? So let's take these one by one. Biliary distension, right? We talked a little bit about this last time. The normal size of the gallbladder is about 7 to 10 centimeters long, right? And less than 4 centimeters in transverse diameter, right? Most gallbladders live within those parameters, right? When you put something in there and obstruct its outlet, right, it's going to distend. And so what we say is, if the thing is greater than 4 centimeters in transverse diameter, it's distended, right? And so we see in the left-sided image here, we're looking at 3 centimeters and change, 3.74 centimeters. And on the right-hand side, we see some, a gallbladder with cholecystitis, right? And the transverse diameter of this thing is about 5 centimeters. And we want to do transverse diameter. It's the most accurate way that we can do it, as opposed to like an AP, given some of the artifact that you might see. Just a nice transverse diameter is going to give you that best accounting for it, right? The second one is wall thickening, right? And when you talk to the surgeons, this is one of the big things that they would say is instrumental in their decision making. Does this patient who's symptomatic, who the story fits, do they have wall thickening, right? And so this results from some of the edema that happens with the inflammation. Generally speaking, there's multiple ways that it'll appear. You can have it, kind of global across the gallbladder or focal. Unfortunately, in isolation, if you take kind of this one finding outside of the context of what's going on with the patient, it doesn't necessarily is not necessarily specific for cholecystitis, meaning that there's a lot of things that can cause gallbladder wall thickening. I got a list here in just a minute. But specifically in cholecystitis, what we have here is just an example of the gallbladder wall that is super duper thick, right? So we consider less than 3 millimeters to be normal thickness of the gallbladder wall. And so as you begin to inflame this thing, it'll thicken up and you'll have something greater than 3 millimeters in thickness. What I've oftentimes seen is, there may be some diffuse thickening kind of globally, but I'll oftentimes see areas that are kind of patchy where we have some worse thickening than other areas. And so it's kind of this heterogeneous thickening of that gallbladder wall. And because it's an inflammatory issue, because there's a lot of edema in that wall, you'll kind of have this kind of heterogeneous appearance of the wall itself, right? Just kind of this really ragged, ratty looking, mouse eaten kind of look, view of that gallbladder wall. Now, like I said, there's multiple things that can cause gallbladder wall thickening. So you have to be really, really careful. It could be a reflection of a patient with ascites or heart failure or renal failure, if they're hypoalbuminemic, or if they have what's called adenomyomatosis, right? Or even like, neoplasms of the gallbladder wall. All these things can cause thickening in these patients. And so if you have a patient with known liver disease, known heart disease, no kidney disease, and they have a gallbladder wall thickening, you have to either look back and see, did they have this before, or at least take that into account. Is this potentially a secondary cause of the gallbladder wall thickening, not just cholecystitis, right? The other one that I didn't have on this list, but it's important, is that gallbladder wall contracted, right? Because if you have a contracted gallbladder wall, that will also appear a little bit thicker than normal as well. And so again, if you say, I have just thickening, this has to be cholecystitis, you have to use a little bit more clinical intelligence in that one, and incorporate it into the whole broader picture, right? So moving on though, pericholocystic fluid is the next thing, right? And we'll see these little whiffs of fluid oftentimes around the gallbladder. Now again, you got to be careful in patients who have liver disease, because they may have ascites, right? You may see evidence of that ascites fluid, which is not pericholecystic fluid, although by definition it's next to the gallbladder, but is from a different source, right? But when you have these patients with cholecystitis, you'll oftentimes have fluid leakage around the gallbladder, creating these small little anechoic areas around the gallbladder, causing resulting in this pericholecystic fluid. So this is a secondary finding of that cholecystitis that you oftentimes see, right? And the final one is kind of goes without saying, the sonographic Murphy. So as you're scanning over the patient, take note of where they hurt the most, right? And if it's right over top the gallbladder, chances are that gallbladder is what's causing some of their discomfort and some of their pain, right? So the question then remains, how good is my ultrasound? Can I trust this? Can I trust me doing this, right? We talked a little bit about what cholelithiasis looks like, what cholecystitis looks like. That's all on top of the foundation last time of kind of what a normal gallbladder should look like. But now, as I take this to the bedside, can I feel justified doing this for my patients? Am I providing some benefit, or only kind of interesting myself from an academic standpoint? So if we take a walk down kind of the history lane here. The first study we're going to look at is from November of 1994, right? And I know this goes in the Wayback Machine, but this was basically a study looking at using ultrasound for gallstones, right? And it basically found that for cholelithiasis, ultrasound itself had a sensitivity and specificity of 84 and 99% respectively. And for cholecystitis, maybe not quite as good, of 88 and 80% respectively, but still quite good. And so the conclusion of the study is, hey, ultrasound is a great first test to do for patients that you're concerned has biliary disease, right? It's got good test characteristics, but also it has some things that other modalities don't. I mean, first off, plain film x-rays just won't see it. The test characteristics aren't there, right? But ultrasound does not have ionizing radiation, right? It's sound energy. And so it's considered to be safe for children and safe for pregnant women, right? And so when you have particularly those cohorts, but generally everybody who you're concerned about biliary disease, going to ultrasound as your first choice is highly justifiable, in especially the early literature, but subsequent literature as well. The second one is basically a 2013 study looking for cholecystitis. And we're trying to answer the question of, okay, what defines cholecystitis, right? What are the test characteristics around that one? And so this is reviewing some of the literature. And the key statistics in this study is basically the sensitivity and positive predictive value for different components, right? So they said a sonographic Murphy has about an 88% sensitivity, right? So if they're not tender of your gallbladder, probably got to keep looking, right? These people are probably going to be tender of the gallbladder. We're going to see this replicated in another study moving forward here. And then if you have stones plus thickening, man, that really increases your odds that this patient has cholecystitis. Again, individually, in isolation, I'm going to keep hammering this one, these sonographic findings aren't sufficient to make the diagnosis. But when you have a patient who has a typical clinical story, right? Right upper quadrant pain, nausea, vomiting, maybe pain worse after they eat, and you find these things, man, this is really highly concerning for cholecystitis, right? So that's this study. Next one is a systematic review, meta-analysis of cholecystitis, comparing other different imaging modalities, right? And so what this one's trying to illustrate is ultrasound may not be perfect, right? But it certainly performs competitively with other imaging studies, right? So comparing this one with HIDA scan, MRI, and CT scan, right? So the sensitivity for CT scan may outperform, at least in this study, ultrasound a little bit, but man, ultrasound really overperforms in the specificity side compared to CT. And for us in the emergency department, that's kind of the most available other test that may be helpful. And so here, I think the takeaway is, when you're concerned, right, and you see it on ultrasound, you probably got it, right? Saying ultrasound's a justifiable first test that you should use to evaluate for cholecystitis, right? Now, HIDA scans may outperform, but I don't get those routinely in the ED. And certainly MRIs are not immediately available. Even though I have an MRI machine, getting one in the ED is going to be this huge, prolonged, protracted affair. And so for similar test characteristics, the ultrasound, performs a lot more quickly than the MRI machine. So that's a lot of radiology level literature, and I'm sure there's a ton more that we're not even talking about. But if we shift our focus towards some of the ED literature, we can see that we still have a test that performs well. And so this is some of the early studies, or this one of the early studies about emergency physicians doing ultrasound, looking for cholecystitis. And they showed a sensitivity of 92% and a specificity of 78% when we do it for these patients with cholecystitis. And then in an ACEP review that was published many, many years later, there's an aggregate sensitivity of 90% and specificity of 88% for us doing bedside ultrasound, which as we look at it, and this is looking for patients with symptomatic biliary colic, as we look at it, these numbers are starting to look very, very similar to the radiology numbers that we saw in a couple slides ago. And so I think the justification here is ultrasound is good to find it and to begin with. When you compare radiologists doing this with emergency physicians doing this, we're coming up with similar statistical outcomes. And what we may lack in some of the specific, and high-level training that a radiologist may have, we gain and we benefit from having that very intimate clinical understanding of these patients and being able to select the patients appropriately for the particular study that we're trying to perform, right? Moving on to Academic Emergency Medicine 2010. This was a study by Chris Fox and colleagues out at UC Irvine. And Chris did a lot of early studies in gallbladder ultrasound, justifying our use of it in the ED. And so what he wanted to show is radiology performed ultrasound versus point of care, so RADIS versus POCUS for cholecystitis. And he really showed comparable test characteristics. So in this table here, we see in the left column we see the bedside ultrasound. In the right column we see the radiology performed ultrasound. And your sensitivities are within a few points of each other. The specificities are within a few points of each other. And the LR positives and the LR negatives are actually pretty close to one another, saying that when we're looking for it compared to when radiology is looking for it, we really perform very, very similarly, definitely with inside confidence intervals, for these two different studies looking for this entity, right? And what I found particularly interesting in this study is he had a really nice table where he broke out the specific test characteristics and showed how each test characteristic matched up with the ultimate outcome, right? What's the sensitivity specificity for the sonomurphy sign, the gallbladder wall thickening, the pericholecystic fluid. And interestingly enough, the one that performed the best from a specificity standpoint, meaning I see this finding, the patient has the disease, is the sonographic Murphy sign. Now, interestingly, it was performed by radiologist, was 96% there. But if you look across the different columns, or look to the neighboring column of the point of care, it still performed quite well. And what also is interesting as you look across these, the other findings, gallbladder wall thickening, pericholecystic fluid, also had pretty good, not perfect, but pretty good specificities. And so the takeaway here is, while each of them individually aren't perfect, right? When you start layering one of these on top of the other, right? When you have a patient, the right clinical patient, right, who then has gallstones, who then has wall thickening, who then has pericholecystic fluid, who then has a sonographic Murphy's, you start layering and adding justification for why this patient actually has cholecystitis and increasing the probability that they actually do. So you can feel very confident when you call your surgeons when you have kind of these layering on of all these different test characteristics, right? Next study here is published 2015 by Chris Fox and his colleagues as well. And I found this one interesting, right? Because one of the critiques that, we can have, or maybe the aggregate critiques that I've heard over the years is like, man, this isn't easy. I don't feel confident. And particularly, I can't find this common bile duct, right? And so where ultrasound shines, or bedside ultrasound shines, we have a quick, easy yes, no, question that we can answer, and then it kind of has a very clean then, if then else, outcome. And so the problem is when you have some of these diagnostic modalities, there's a lot of nuance that it's involved, and some of that nuance can be scary and can keep some newer, less experienced people away from doing this study. And so what Chris was looking at here is, if I have a patient who has 0 gallstones, like what's the probability they actually have cholecystitis, right? And what they presented here is that if you don't have stones, you don't have cholecystitis, right? At least in this paper, right? Now, if you have stones plus secondary findings, now again, our test characteristics are starting to revert back to that mean of what radiology and what other studies in the ED will report for sensitivity and specificity. And so I think this is really helpful, right? We have to understand this, though, in the context. We have to nuance this paper just a little bit. I think it'd be very inappropriate to say all patients with 0 stones don't have cholecystitis, right? Because there is this entity called acalculous cholecystitis, which by definition is cholecystitis without calculus, without stones, right? And so where the way I interpret this paper is, if the patient has right upper quadrant pain and you scan them and they have a clean, super clean, absolutely normal gallbladder, right? Normal wall, no distension, no pericholecystic fluid, doesn't hurt over top the gallbladder, and there's no stones, this is not your patient with cholecystitis, right? Now, if you start adding some of those things, right, you have maybe an acalculous cholecystitis tends to have, risk factors, elderly, nursing home, diabetes, and they're going to have gallbladder wall thickening. You may have some pericholecystic fluid. So if you start layering some of those things on, but you don't have stones, this is where the paper breaks down. But for the vast majority, 90 some odd % of the patients that you scan, if they don't have stones, you need to start thinking about some other etiology for their right upper quadrant pain. And this paper would justify that. And the final thing that I want to show is a study that we started working on a number of years ago. This is an abstract or a poster that we presented, basically trying to say, I was trying to answer the question, like, I hate doing these studies and then have the surgeons come back and say, oh, well, can you just get the formal ultrasound because I don't trust your scan? And over the years, the need for this study has definitely been obviated a little bit because as point of care ultrasound has grown, it's become more ubiquitous, more people trust and understand kind of what's going on. More surgeons are willing to take patients to the operating room based on our studies, at least in my experience here. But this goes along with a couple other papers that have been published in the last few years saying, okay, if I do the ultrasound and then I follow it up with a radiology performed ultrasound, are they different, right? Our hypothesis is that they weren't, right? Yeah, there'd be some that, maybe due to operator skill, they were a little bit different, but our hypothesis is that in aggregate, en masse, that there would be pretty much uniformity between the radiology performed and the ED performed ones. At least that's what the studies we talked about earlier today showed. And so what we did is we looked over 20 years at all the ED performed ultrasounds that we did, gallbladder ultrasounds, that also had a radiology performed ultrasound done within 24 hours, generally is after the ED performed ultrasound. In fact, I think if I remember from our person who ran the numbers, they were all performed after the ED performed ultrasound. And then we gave them a clinical scoring system, right? We scored each individual element, got an aggregate score per study, for both radiology and ED, and compared that aggregate score to see, how similar those scores were. And what we found, that kind of graph in the middle, is that most of the studies had no difference in the two different scoring systems, right? There was a little bit of variability on either end, but most of them showed profound similarity between the ED performed and the radiology performed ultrasound. And in fact, what was interesting is where we found differences is certain things weren't reported out more often in the radiology performed studies than the ED performed studies, largely because I think we have a template that we use for our results. And so it was hard to find. There's a lot of studies that kind of had to fall out of the picture because the ED reported something, radiology maybe didn't. And so, but the whole point of this is there was profound degree of similarity between the two different studies, kind of justifying that idea that if you do it and you call it, okay, they may ask for the comprehensive ultrasound, but feel confident that you're probably going to come up with a similar results, as if you did it, at the bedside by yourself. And so kind of all this goes to kind of paint that picture of, gallbladder ultrasound is something that's certainly within the wheelhouse of what we can do. For us in the emergency department, it's one of the recognized modalities by the American College of Emergency Physicians, right? It's something that's ubiquitously done for right upper quadrant patients in the ED. It should continue to be ubiquitously done because it's a very easy, quick screening modality for these patients. And when you find something, then you can, obviously kind of pull the thread on that and get your surgeons involved and kind of start deciding, is this something that's going to end up needing operative intervention or not? So with that being said, that kind of wraps up what we want to talk about today. Are there any questions, from today, from the previous time, kind of as we move forward with, with other topics here? Well, with that said, thank you guys for joining us today on Ultrasound Grand Rounds. Enjoyed giving this one, kind of helpful to talk through it. We had a little bit of discussion kind of about some techniques and tips and stuff like that. If you want to go back and review some of the old stuff, go back to the previous lecture that's posted up on YouTube here. While you're there, hit that subscribe button, that notification bell, so you can be notified when all these lectures come out. And we'll see you guys next time. Dr. Werner's going to be talking about liver and spleen and all the good stuff that lives in the belly as well. Looking forward to that one. We'll see you guys next time on Ultrasound Grand Rounds. Bye.